This is an important conversation because I think it's a confusing one, and just to tee everybody up in our communities together. I'm the co-founder and CEO of FertilityAnswers. I am a cancer survivor and a fertility preservation success story. So Serena and I get together every week, Dr. Serena H. Chen, and we talk about things that we see on the Fertility Answers app platform are brought up on kind of a consistent basis, or they're brought up in social media. And we try to debunk myths. We try to get down to facts. We have a shared mission of ensuring people have democratized, meaning free access to personalized education and information, and kind of a joint mission in that we also really want to see people get in for an infertility consult as soon as you think there might be a problem, or if you are gearing up to try to conceive and you already know that you have irregular periods or luteal phase defect or something else like that. We don't want to see these long delays when it comes to people getting access to care. So with that said, as Serena already teed us up, today is all about luteal phase defect and if that's a thing, so also known as LPD.
LPD, luteal phase defect.
I think we have to start with what's luteal phase. Let's start with the basics,
your
Serena.
Your menstrual cycle has two phases. They're called the follicular phase and the luteal phase. And the luteal phase is for the moon. So I guess people like that harkens back to all the mystery of fertility and reproduction and, how women are witches because, we can grow babies in our belly, things like that. I'm not totally sure, but luteal phase stands for the second half of the cycle. In a typical 28-day cycle, the luteal phase is once you ovulate, progesterone rises. So that tends to be about 14 days, 10 to 14 days. And the first part tends to be, 10 to 14 days. And that usually adds up to somewhere around 28 days. So it's just the second half of the cycle.
Now, not every doctor believes that luteal phase defect is a thing.
Right.
So, or that it'll cause infertility or miscarriages. So can you back up a bit for why can't we come up with a consensus around this?
Well, because we know that the corpus luteum, which is the organ in the ovary that the follicle becomes. So the follicle holds the egg. It's a sac that holds the egg and grows the egg and matures it. And then LH surge, you release the egg. The egg then goes off, to the fallopian tube and hopefully meets a sperm. But the sac that the egg was in, which has a lot of cells and steroid producing cells, then changes over from producing just estrogen to producing estrogen and progesterone. And that's what supports the early pregnancy. So when you have a pregnancy, you make a hormone called beta HCG, which is very similar to LH, and that keeps the corpus luteum growing through the first few weeks of pregnancy. So the corpus luteum is supposed to make both estrogen and progesterone. If you take the corpus luteum out, you will actually cause a miscarriage. So that's in the early days before we really knew what all these hormones meant, when they used to do like experiments on rabbits and things like that, if they would take out the corpus luteum, or if somebody had emergency surgery and lost their corpus luteum, they would lose the pregnancy. So they figured out that the corpus luteum is making these special hormones, and it's like called, corpus luteum means golden body. So the luteum means gold actually. And because it's full of the cholesterol, which we need to make the steroid hormones. And so a luteal phase defect is potentially a cause for infertility and miscarriage, because if you're not making enough estrogen and progesterone during this critical part of the cycle, perhaps you wouldn't implant, your embryo would not implant, and you wouldn't get pregnant. So that could cause pregnancy.
Might that be the case, Serena, if people are having like recurrent chemical pregnancies, really early miscarriages?
Theoretically, it could make a lot of sense, but we don't
have the data,
evidence
right?
that that's really what's causing chemical pregnancies. Because that it just we haven't really seen a lot of data on that, because we don't understand chemical pregnancies very well. The big issue with luteal phase defect and why there's so much argument about it is because we don't have any good data. There's no good way to measure progesterone. You can measure it in blood, but measuring it in blood does not necessarily tell you what's going on in the uterine environment. And measuring it in the uterus would actually be much more accurate, but that's only half the picture, because the other half of the picture is how you perceive progesterone. So if you did not, you could have all the progesterone in the world, and if somebody didn't have enough progesterone receptors, it wouldn't matter that there was progesterone around.
Because the receptors allow for the body's usage of the progesterone itself.
Exactly.
So that's the issue there, is that you could be producing enough. You could be supplementing it. You could be supplementing a ton, right? But if you don't have the receptors for the absorbability or for the usage, then that could be a problem. So I understand what this is a big clinical challenge for you all, because you don't have access to the uterine information all the time.
It drives us absolutely insane.
Right.
Insane.
Right.
We have no idea what's going on inside the uterus. And meanwhile, a lot of people, human tendency is to say, well, more is better. So if I might have a luteal phase defect, let me just take more and more progesterone. And I always worry about the fact that giving more progesterone can accelerate the closure of the implantation window. So in some ways, if given the wrong way, in the wrong amount, progesterone could actually have kind of a contraceptive effect.
Oh, interesting. Okay. I had never considered that. And we have somebody who's watching, Leah Dreams in Yoga. I love that handle. This is exactly what she's going through right now. And some of the other symptoms, though, that if somebody has a luteal phase defect, might be spotting between periods, too frequently having periods, which could,
or have short periods, really late ovulation, short luteal phase. So it might not be just the amount of progesterone that's secreted that might be inadequate. It might be that the phase is too short. And, so we do all kinds of things like giving extra progesterone, but you have to know what's going on with your cycle. Otherwise, again, you could actually prevent, release of the egg. You could close the window and do exactly the opposite of what you're trying to do. So it is important to be monitored and to make sure that your doctor, is not just throwing you on a bunch of hormones just to get you out of the office. They really need to know what's going on with you. Clomid might be another way to improve your luteal phase defect. Even though Clomid works in the follicular phase, it's thought that perhaps a poor luteal phase is a result of a dysfunctional follicular phase. So if the follicle doesn't develop normally in the beginning, then, it could affect you in the second half of the cycle.
Got it. Okay. This is a lot to take in. I mean, I think that what I'm hearing, Serena, is that as clinicians, you are challenged by having all the diagnostic tools kind of even invented yet to help even diagnose luteal phase defect. And then once you do, there are multiple options to how you treat your patients that don't always have to include IVF.
Yeah. And I feel like, is luteal phase defect like an identifiable syndrome? I'm not sure. I know that any woman at any point in time might have like a funny cycle and not be producing that much progesterone. I see very commonly after women are coming off of years of birth control pills, the weirdness that happens for 3 to 6 months before they'll regulate, that often is filled with luteal phase defects. Teenagers, when they're going through puberty, often will commonly have luteal phase defects and anovulatory cycles. It's just a matter of, just something being off with your cycle. So you could imagine how being super stressed or gaining a lot of weight or losing a lot of weight, all of this could affect your cycle. So just because maybe you have a luteal phase defect or a low progesterone 1 cycle doesn't necessarily mean that you're always going to have that.
We got a great question from Leah Dreams in Yoga, which is around, can it be related to PCOS or endometriosis?
So PCOS, I think it definitely could be in an endometriosis, both, but in different ways. Like endometriosis, we don't understand very well, but a lot of people with endometriosis, especially stage 3 and 4, will have diminished ovarian reserve because the endometriosis is literally destroying the eggs, the tissue in the ovary. And anybody with diminished ovarian reserve is at risk, I think, for a type of luteal phase defect because they're just, not making as much estrogen and progesterone and things like that. And then PCOS tends to make lots of estrogen, and then maybe if they don't have a good, strong ovulation, that you could see how they might have a luteal phase defect because they don't have a good, strong ovulation. But of course, PCOS patients have completely the opposite problem of diminished ovarian reserve patients, and a lot of endometriosis patients have diminished ovarian reserve. Now, some endometriosis patients with perfectly normal ovarian reserve will still have weird spotting, which we don't know what that is. That's like often maybe some instability of the lining of the uterus and not necessarily a luteal phase defect because of all the inflammation that's going on in the uterus and the pelvis with endometriosis. That the spotting is super, super common. I'm not sure we understand that super well.
Now, Nicole, I think it's Nicola Lemming, SW Southwest, maybe that means, mentioned that she has already irregular cycles. She's been trying for 17 months and her gynecologist won't help until she's lost, it says 4th, maybe. We get very upset when we see things like this.
Workup. Yeah,
you need a workup.
Yeah.
You've already been trying to conceive for over 12 months. I can't tell from the tiny picture if you're under the age of 35 or not, but this is a good reminder for everyone. If you've already been struggling, if you already have something like irregular periods, or you even have a diagnosis of something, get in for a full workup. And if your gynecologist is not being supportive, find a new one.
Yeah,
you absolutely deserve
even if
to have this access.
Absolutely. Even if you have no risk factors and you've only been trying for like 2 seconds, or you're even thinking about trying, if you want information, you should be able to talk to your doctor about it. You should not be dismissed. Certainly you could be reassured, but being dismissed and not taken seriously, that's not okay. We're here for. Yeah.
Listen, just last week I had to go to a new primary care doctor, and I have a new type of insurance. So I had to go to a new primary care doctor to get all my referrals lined up. And I said, here are all the labs that I want. And she said, and this was completely in her realm, she said, I don't like to order labs in which I don't know how to interpret the results. So if it's okay with you, I'm going to refer you to an oncologist because I need a current lab work done for just oncology following. And there were some other ones that I wanted. She said, so I need to refer you to a gynecologist, refer you to an oncologist, refer you to this person, that person. And it was a dialogue, and also a dermatologist, because I have this huge history of skin cancer in my family. The point is that she heard me. She said, I hear you. You're an empowered person. I hear what you're asking for. So I'm going to set you up with all the people who can get those particular labs. And she said, here are the current set of labs that I can get that are wellness labs for cholesterol, my lipids, my vitamin D levels, things like that are common. But if someone isn't listening to you, we put our foot down and we say, that's not the right person for you. Because if your gynecologist isn't going to do a full workup, then you need to get in to see a specialist. A lot of patients on our Fertility Answers app platform don't even make that first consult appointment because they feel like, A, I can't afford it, or if I need treatment, I can't afford it. And what we want is to see people just get the consult. If you were diagnosed with cancer, like if irregular periods was the equivalency of a cancer or a skin cancer risk or high cholesterol, you would get in to see the appropriate specialist right away.
Yeah.
If you had a bum knee, you would get into an ortho specialist right away. So if you know that there's already a problem like irregular periods, painful periods is another example, skipped periods, whatever it might be, now is the perfect time to get in to see a specialist, and your insurance should cover that visit. And if it doesn't, you can please reach out to me privately on the Fertility Answers app platform, or just, through even Instagram, to help you navigate insurance advocacy, because specialty healthcare is a covered benefit across the board. And there's some state issues with accessing that coverage.
Yeah,
but
so
we're
you
here to
might
help.
need a little extra hand-holding, which Fertility Answers definitely has navigators to provide for you specifically for that, so you can navigate a complicated system. A lot of people are saying like all their hormonal testing is normal. Just because all your hormonal testing or your entire evaluation is normal does not mean you would not benefit from treatment. A lot of people, because the fertility evaluation these days is relatively simple. We used to do surgery in the old days on everybody, but we found that surgery doesn't really improve your pregnancy rate and doesn't really give us extra information that we need to help you get pregnant. So a lot of people fall into this unexplained category and are told everything is normal and get really frustrated. And it does not mean that this is in your head. It just means that we have a problem finding a specific cause. And honestly, I know it's really frustrating, but we often will never get you the answer. But that's okay, because usually we can get you the baby. Fertility. I think
that's a really important thing.
Yeah.
That we have to underscore that, like bold it, underline it. Even when they don't know the cause, the science and technology is so good, they can usually get you the baby.
Yeah. And we have answer, yes, baby. That's how it is right now. It's just a function of how we obtain information and get and just the way the field has developed. So and then somebody had a little question about like it's early. I just had my embryo transfer. I'm pregnant. I'm feeling nothing. Is that normal? And yes, that's totally normal. Some people feel, believe it or not, nothing for the whole pregnancy. Feeling nothing is okay. Feeling a ton is okay. That is
it's a huge range, but that's very exciting. Congratulations on doing your embryo transfer, and fingers crossed, that everything is where it's supposed to be. We know the 2-week wait can be unbearable, and the reason that doctors say don't do at-home pregnancy tests is because we all try to do them too early and too soon, and then we drive ourselves crazy. And our best advice is just to distract yourself as much as humanly possible and get really good sleep, if that's possible. Get really good sleep so that you can manage your cortisol levels and keep your stress as low as humanly possible. But it's only been a few days, so it's super normal that you wouldn't feel anything at all. Somebody else, Puggy Willis, asked what causes failed IUIs. That is a giant whole show, probably will be dedicated to that. But in a nutshell, Serena.
Not a lot of IUIs don't work. It doesn't mean you're not fertile or that you can't have a baby. It's just like the IUI has a limited a ceiling on the pregnancy rate of about 10 to 15%. So if you don't get pregnant, that can be normal. It's definitely for a lot of people worth trying a couple times, but yes, definitely something we should talk about more.
Yes, and then Nicola Lemmings, SW, asked a really important question. We've done some of our content around weight and cycles is on YouTube, and we'll do some more Instagram lives on this topic as well. But yes, weight absolutely can affect cycles. And Serena, why don't you talk a little bit, just very briefly, about just the positive impact on a little bit of weight loss on cycles?
Well, even if somebody has a large amount of weight that they think is excess, we see really positive results with just 5 to 10% weight loss. So somebody is like 200 pounds and they're supposed to be 150, 50 pounds seems like a lot, but if they lose 10 pounds, 20 pounds, just a little bit, we can see a significant drop in the insulin resistance, in the resting blood pressure, sometimes in your cholesterol, things like that. And I don't want you to focus so much on the pounds, though. It would be more like, eating more vegetables, avoiding sugar, getting better sleep, getting some good exercise in, not just cardio, also strength. So, yeah, it would be nice to be a less pounds. It's a sign of progress, but we don't want you to obsess over the weight, because we want you to concentrate more on being healthy. And intermittent fasting, I think, is something we really want you to take a look at and think about doing. Of course, talk with your doctor first.
Yeah, and then look at the talk we did. We have it on Instagram TV. Casey, who's our social media manager, and myself talked about the Life as Imagined program. I went on it and I lost 10 pounds of 15 to 20 that I could afford to lose because I'm gearing up for an embryo transfer this fall myself. And I just wanted to, I know, I'm so excited. So I will be following my journey on this as well. But I think these are great questions. Nicole, I think it's Nicola Lemming or Nicola Lemming. I'm probably butchering all that, but I appreciate the questions, because these are things that if you only get 7 minutes to talk with your OBGYN about, it's not enough. We're trying to bring all the education so that you know what questions to ask and what to expect from your gynecologist when you're in the office, because we get such a short period of time, with them. Let's see,
and
Drew.
Here's somebody talking about second child infertility. What date did we do that on? Because she can look back.
I think it was last week, wasn't it? Or 3 weeks ago?
Week before?
Might have been the week before. So we do have a whole show on secondary infertility. Yes.
Yeah.
And that you can find on YouTube. And if you DM us, then we can just send you the link. So send us a DM if you're looking for the secondary infertility content. But our YouTube is Fertility Answers.
But it is common. It's very common.
Very common.
You're not alone. You're not alone.
And we recognize the pain involved, and that it's not okay for people to say, well, you already have a child, you should be happy. It's not okay for people to say that.
The good news is you have a baby, that usually puts you in a very good prognostic category. So that is something to hold on to. I think that's
when I had my first miscarriage, somebody said, it's a good sign you got pregnant. I wasn't ready to hear that. Yeah. I wasn't ready to hear that. I mean, I had five miscarriages, and feel very, very happy and lucky that I had my embryos. By the way, Serena and I are doing a whole show around egg freezing tomorrow on her channel. If you want to come back and hear my story in detail, but I am very lucky that I had some embryos that were frozen.
Yeah, because Alice, you have a great story to tell, and that will be not on it will be on Fertility Answers and IVF _IRMS, my practice, Institute for Reproductive Medicine and Science, which is a mouthful.
Yes.
So, but
we also have, Serena, we also have from Drew. She found out she only has one fallopian tube functioning. And she also has pelvic congestion syndrome and Hashimoto's. So I feel like there's 3 shows in one for that, 3 episodes in one that we should talk about. But let's just address today the one fallopian tube functioning, because it's hard to know which side is ovulating unless you do an ultrasound scan to see which one ovulated.
See, I don't worry about that so much. I feel like the sperm are supposed to go everywhere, and the egg comes out of the ovary, and if there's not too much scar tissue in the pelvis, the open tube will pick it up. So I don't focus so much on the side, although there is a lot of people do feel like if it's on your good side, you have a little bit better chance of getting pregnant. I think very important to be monitored for tubal pregnancy if you get pregnant. So 2 weeks after ovulation, even if you have a little bit of bleeding, you could be pregnant. It's very important to just check a pregnancy test and be super mindful that you are at increased risk for tubal pregnancy, which can be dangerous. But one tube, you can definitely get pregnant.
And it's important, though, you can get pregnant if there's a healthy quantity of sperm that can get there. I mean, I think that we focus so much on women's issues, and I see so many women on our app say, no, it's not my partner because he already has, a child from a previous relationship. But sperm parameters change.
Yeah.
You got to have the sperm checked. Yeah. Yes, because if you only have one tube functioning, plus you have some other things stacked against you with the Hashimoto's and the pelvic congestion. I don't know what pelvic congestion syndrome is, but Serena does. And
I don't really know that it's a real thing.
Oh, okay. Well, that's important. So we'll maybe address.
That's a term I haven't heard in I think 3 decades, 3 or 4
decades. Oh, wow. Okay.
Yeah.
That's important to understand.
Kind of an old-fashioned term.
Okay.
And I wonder if whoever told you that was like trying to explain some other concepts. That's the hard part, is like
Right.
when you go to talk to the doctor trying to absorb everything. And, so it's helpful to get notes and, maybe bring a friend or something with you. Somebody has 4% normal forms on their sperm. That can be fine. It depends on the lab. It might be a little bit low, but it depends on the particular criteria that was used. So definitely talk with your doctor about that. And then I have PCOD. Can follicular study get me pregnant? I think with PCO, sometimes you're not ovulating. So a lot of times you do need help ovulating, and that you might see your gynecologist or a reproductive endocrinologist for. And then somebody had a miscarriage after a PGT normal embryo transfer, which does occur around 10% of the time. That's much lower than the normal rate, which is 25% or higher.
Yeah.
But it doesn't mean the whole batch is bad. You
Right.
have other normal embryos, keep going. There's a baby in there somewhere. Just
okay,
keep
but
going.
this is that question that was a perfect lead into the controversy around ERA testing.
Right.
So the
that's
uterine
true.
receptivity testing, and we didn't touch on that with this whole topic of luteal phase defect and whether you
That's
need
related though. Yes, you're right. It's related.
So, would you recommend, and somebody even asked on the app recently, they said, if I do ERA testing, is it painful? Somebody asked that on the app recently.
Yeah, it can be kind of painful, but it only lasts a few seconds. So you might take Advil, like if you can take Advil, a couple Advils beforehand, talk to your doctor about that. But the person who had a miscarriage after a PGT normal embryo does not actually meet any ERA criteria. So ERA criteria right now is 2 failed implantations after PGT normal or donor egg embryos.
Got it.
Transfer.
So just failed implantation, not miscarriage. So there might be something else going on genetically.
So the fact that she had implantation and then miscarried, it's kind of reassuring about the uterus, and probably just means the embryo had other things going on besides having normal chromosomes.
Right. I mean, we talk about that a lot, pretty much on every time Serena and I chat, this comes up, that PGT is limited in what it can test. It doesn't test, it's not the whole entire genome. It's not all the billions. And so I think that that's the biggest surprise that people have when it comes to PGT testing and transferring, normals. I'm about ready to do the same thing. I have 5 normals that were frozen when I did my last frozen embryo transfer, and they're all normals, but it doesn't mean, that I'm heading into this transfer expecting, the same success that I had with my son, because we only know what we know, but there's still lots of information about the embryo that we don't know. And that's the devastating part. That's the part that's really hard.
Drew is asking, well, if it's not pelvic congestion syndrome, what should I do? I'm not sure what's done for pelvic congestion syndrome. You have the Hashimoto's, definitely your thyroid should be monitored. If your TSH is above 2.5, think about like some thyroid replacement. You should be seeing a thyroid specialist, should be seeing a reproductive endocrinologist, because I think if you're having infertility and miscarriages, then you might benefit from some fertility treatment like IUI, IVF, PGT, something like that might be helpful. So those are things I think that you should think about exploring.
And just a reminder, when you register on the Fertility Answers app, either iOS or Android, we do match every single user to a genetic counselor in your state. And it's the most economically conscious company, meaning the prices are the lowest. And you can always pay for it and then submit it to your insurance. But if you have had miscarriages and you want to connect with a counselor to understand what it could mean genetically, then by all means, just hop on the app so that we can match you to a counselor in your state. And that's Alice, for anybody who's ever had at least one. I think we have so many questions,
but we're like running out of time. So we're going to
have
you come back again. But I'm going to see you tomorrow at 4:30, right? 4:30.
Yes, 4:30, 1:30 Pacific, 4:30 Eastern.
Yeah.
We will take all of these questions.
And IVF_IRMS. We're going to talk about Alice's egg freezing journey, because she's an egg freezing success story.
So hop on. I'm getting ready to do another frozen embryo transfer. So we'll hopefully see you all tomorrow. And if not, we'll see you same time on Instagram Live. next week, every single Monday. We transitioned from our YouTube, Facebook Lives to this platform because we love our community so much. We love you all. We're here to support you. Ask your questions on the Fertility Answers app.
Yeah, go to the app because I know we didn't get to all the questions. I apologize.
Exactly.
It's so many good questions.
That's right. You can ask all these questions anonymously on the app, and we have multiple experts who can answer, and even experts in your own state that can answer your particular question. So thanks, everybody, for joining us. We'll see you next time.
Thanks,
Serena.
Thanks.
Love you.
Bye.
Bye.
Love you. Bye.